Hi, everybody. This is Dr. Lisa Finkelstein with Beyond Telehealth, and welcome to a snowy, rainy day in Jackson Hole, Wyoming. My special guest is going to be Dr. John Lynn, but he is late in the operating room, so I'm going to get started just to stay on time. And what we're going to talk about today are updates for telehealth in general. What I've been hearing through the echo chamber from physicians is that everybody is worried about what's going to happen after the public health emergency ends with the telehealth waivers. So let me go back in time to the beginning when this started. So the public health emergency started in 2020, March 11th, with HHS literally taking down these barriers to allow physicians and providers to practice telehealth. Prior to that time, it was pretty arduous to get telehealth up and running. And I know that because I practiced in Wyoming and helped develop 5 or 6 originating sites. And I'm going to explain what that is so you understand. But the public health emergency brought forth over 135 telehealth waivers, allowing telehealth to be practiced much more easily. And most importantly, for physicians, they were able to then bill and code for telehealth visits with full parity. Now, what that means is that doctors bill patients when they see them face to face in their office. But when they would see telehealth patients in urban areas, oftentimes they weren't allowed to bill unless they were in a rural setting. So for me in Wyoming, I could get these programs set up and bill CMS and get paid the same amount as I would if I was seeing a patient face to face. So what physicians are worried about is that when the federal government says that the public health emergency is over or is terminated, then the rules and regulations are going to go back to pre-pandemic. So I want to be your source of accurate information for physicians so that they understand how this works. So right now, the public health emergency has been extended as of April 16th, and this is the 9th extension from HHS since the beginning of the pandemic. So what's going to happen is that every 90 days, they extend the public health emergency. So this now is extended through to, let's see, July 15th, 2022. Oh, hold the phone. I see Dr. Lynn. There he is. Dr. Lynn, take a breath. Ooh, ooh. Little bit of echo.
Maybe I need to do something and turn on echo cancellation, maybe?
There you go. I'm echoing.
Okay, echo cancellation, I just turned it on.
All right.
How are we doing?
We're good. So I am great to see you. I'm in the process of just giving a little bit of background. So give me a minute. I'm just talking about what the public health emergency extensions are so everybody understands.
Wonderful.
So, as of April 16th, it was extended for 90 more days through to July 15th, 2022. So every 90 days, the government extends the PHE. But what physicians are very worried about is that that's going to stop, and then the ability to get full parity for reimbursement with CMS is going to go away. So a couple things is that if they're going to stop the public health emergency, they have told us that they will let us know 60 days prior to that so that we know that it's coming. And then when they end the public health emergency, according to the omnibus bill that was passed in March, that there's 151 days that we still can continue to utilize the tool of telehealth and continue to bill as we are with CMS. Now, let's be clear. I'm talking about CMS. I'm not talking about all insurances and all payers, and that's another discussion. So the first point that I wanted to cover was what's happening presently with the public health emergency. So, John, do you have anything that you want to add?
So what changed recently was an amendment to the Senate HR 2471, and like you said, the at the end of the public health emergency, Congress has extended it beyond 151 days, and I have my thoughts about why they extended it 151 days. But in essence, for the practicing physician, there's going to be continuing relaxation of the telemedicine rules during, as if you're still in the public health emergency, even though the PHE will have ended. And so that extension has to be done by Congress. Otherwise, you would not get the payment and also the relaxation of the telemedicine rules. So for instance, it would revert back to the need to be in a health professional shortage area. The patients will have to be in some special designated originating site, and they wouldn't be able to do it at home. But what Congress did was they extended it 151 days beyond the end of the PHE. And the 60-day notice, it's a guideline. It is not written in law. So HHS Secretary Becerra can say, well, no, we're not going to. Yeah, we're going to switch over, and we're not going to give you the 60 days. And so that is not a law. It is simply a guideline that they may or may not follow. So keep that in mind.
Yeah. Well, I have to say that as an advocate of telehealth and paying attention as you are, telehealth truly is one of those rare bipartisan issues that I have not spoken to anybody in Congress or Senate that has said, I don't like telehealth. So that is a positive for all of us. And so physicians should take note of that in the sense that our legislators really love telehealth because they're patients as well.
It's not just the legislators, the big voting bloc, the Medicare patients, they love telehealth. And it's one of the great things that happened. Unfortunate that we had to have the pandemic, but it was one of the great things that happened to U.S. healthcare is the relaxation of telehealth. It increased, it encouraged mass adoption. And so the patients are used to it. A lot of physicians, providers, qualified health professionals are used to it. And it's like the genie is out of the bottle. You can't stuff it back in.
Right. The toothpaste is out of the tube. So let's talk to our fellow physicians here who are very worried and have been posting on your wonderful Facebook group to say that, if things revert back and I am not reimbursed full parity for telehealth visits, I'm no longer going to provide that. And I want to try to encourage and support and just sort of lower the volume a little bit. So that's another reason why I wanted to do this with you, John, just to, try to explain why, let's jump to that stage yet.
Yeah. First of all, I don't think telehealth. So in general, telehealth, we're talking about synchronized audio and video visits. I don't think it's going to ever go back to the archaic health professional shortage area, designated originating site. I don't think it's ever going to go back there. And what most likely is going to happen is probably, I'm guessing now, CMS is probably going to adopt some version of how they're implementing telehealth for psychiatry, meaning you have to see the patient in person, maybe once every 6 months or once a year, for that Medicare patient to be eligible for telehealth visit. That's what I think. And again, it requires an act of Congress to make this happen. But I'm hoping that's what's gonna take place, irrespective of what happens with legislature, with the law. There are two things that you need, right? You need the law, you need the legislation,
Congress. Yep.
and you need the money, you need the finance. So even though there's going to be relaxation of the telehealth rules, most likely will happen, how the physician or the qualified health professional, how are they reimbursed is probably what is going to drive whether this continues. And even if it doesn't, say they pay horribly, or they may not pay at all. Say that there's no legislation to cover telehealth. There are ways to provide the service to the patient without going through insurance. We are so we're so conditioned.
Brainwashed.
Yeah, we're so green lighted.
Yes.
Gaslighted. I'm sorry. We're so gaslighted
We're
into
like
thinking.
little soldiers that just keep following the same
Right.
paradigm.
We think this is the only way to practice medicine. No, it's not. There are a lot of primary care doctors who are doing direct primary care, which is they don't deal with insurance. They deal with the patient. I mean, let's bring back direct patient care, taking
Right.
care of the patient instead of having insurance company, which sometimes require prior authorization. Really, they're in essence practicing medicine without a license. It's time to consider getting rid of that third party and then deal with the patients directly, provide telemedicine services as a fee for service that you can charge the patient directly, a reasonable fee. I know for me as a patient, I would happily pay cash out of pocket to have a telemedicine visit with a cardiologist, with a neurologist, with a primary care doctor that who doesn't need to examine me. I would be happy to pay that cash
Right.
because my time is valuable. And also with the current gas prices, and forget it, right? What we don't consider is every time you take on the road, get on the road, that is a huge risk. Flying is much safer. Driving is one of the dangerous things that we do every single day, and yet we don't think about it.
Well, so prior to the pandemic, so I live in Wyoming, and I set up 6 originating sites for patients in rural clinics, right? Huge pain in the butt to do that. But it was a requirement, and we were able to get those up and running, and patients were thrilled that they just had to go to their community clinic to have telemedicine. But I always thought that the home was the pinnacle, right? So then the pandemic hits, and I'm like, yes, and not that I love a pandemic, but it is kind of fascinating what has happened. And then also, what I would do with patients is I would say to them exactly what you said. You don't have to drive from Pinedale, Wyoming. I'm going to charge you $50 for 15 minutes. Now, I know that's a lowball thing, but it was experimental at that time. And I never had a patient say no. They happily said, if I don't have to drive over a pass or even get on the Schuylkill Expressway in Philadelphia, to get to my doctor, I will pay you. And that's what these companies have taken advantage of, the direct to consumer. So I am on your page, and we are here to encourage our independent thinkers to say it's okay to say that to the patient. Would you be willing to not submit this to your insurance and just pay cash?
Absolutely, absolutely. So don't be gaslighted into thinking that third-party payment system is the only way to go.
Right.
It's time. The problem is we're so used to doing. It's the same old status quo bias.
Oh, right.
We're so used to doing the things the way we've always done it that we don't think about doing it some other way.
And also, John, for the physicians who are not independent, now your group is very independent, but there are many employed urologists. And it's not also out of the question to go to your managers, your supervisors, your administrators, and propose this, right? To talk to your billers and see how this works. It's another stream of revenue that it's worthwhile for them to look into. I want to jump a little bit to another question, because I don't want to, people aren't going to listen all day to this, but I wanted to just cover a few things. So one is a question that popped up is place of service 10. So we're going to jump to this topic. So let me just, give people a basic to understand what place of service is. So when I first started doing telemedicine, when we had to do it in the rural clinics with an originating site, we had to, that originating site, the definition is where the patient is located. In that rural clinic, that clinic would drop a Q code and they would get paid about $25 from CMS or some private insurers for that facility or that room. I would then drop my code 9921314, whatever, 0304, with a place of service 11 or 02, depending, with a modifier, GT modifier, depending on the payer. And so it was a little bit confusing. So place of service 11 says that the patient is sitting in an office or a clinic. Place of service 02 means that the patient is not in their home. The new place of service that CMS is going to institute potentially is place of service 10, which again is the pinnacle, that the patient is at their home. And so it's a way for CMS to track that place of service. The recommendation right now is, while the public health emergency is in place, is to not use place of service 10. So everyone's in this tizzy about the place of service 10. And right now we're saying, don't use that.
Correct. And I think that's in one of the Medical Learning Network articles that CMS released recently, to hold off on using place of service 10 until further notice. And I think if you submit a claim with place of service 10, your claim may be rejected. So why take the chance?
Right. Okay. So a lot of doctors are getting caught up in the modifiers. Should I, shouldn't, what modifier, what place of service? It's really, it's important that you understand it, but your biller should also be very up to date on how these things work. With CMS, Medicare, with Medicaid, and with the private insurers, because it varies as to what their regulations are.
And that's part of the problem, and that we are talking in general Medicare rules. Yeah. But you may have separate contract with a Medicare Advantage plan. You definitely have different separate contracts with private payers, United, Aetna, Blue Cross, Cigna, et cetera. They all want different things. For instance, in my area, United Healthcare does not want a modifier for a telemedicine visit, whereas Blue Cross, Aetna, Cigna, they want a 95 modifier. So it's very individual, depends on the payer and your billers and coders. There has to be constant communication between the provider and the coder and biller.
Right. And so I would say to the physicians that it would be really important to, and not just with telehealth, but just with everything, is to, become close with your biller, your coders and your billers, so that you guys are on the same page. Same thing with employed physicians. Employed physicians have a tendency to not get involved in that arena and let them do their thing. And I have to say, all you employed physicians, that a lot of the billers don't know, and they don't know, they're not up to date. So if you're watching this, I know that you're concerned, and you are part of the, you're part of the reason why things are successful in your practice. So the other topic I want to talk about is audio only. Let's briefly go into that. So this is another big concern with physicians. So in telehealth, the original rules of telehealth pre-pandemic was real-time audio, video, telehealth. The pandemic rolls around, everyone tries to figure out Zoom, figures out, whatever platform works for them, and realizes that not everybody even has a cell phone. Not everybody even has email. And so we now know the pandemic has highlighted in huge degrees the inequities of our healthcare system. And telehealth has been front and center for that. So physicians also don't want to have to take the time to educate patients on how to download an app or how to download, Zoom onto their computer. And so they then go to audio only. Well, the statistics are mind-boggling as to how many physicians and patients say, I'm just going to use my cell phone. I'm just going to use the telephone. The statistics are starting to come out, and they are seriously looking at audio only. But as we know that and are afraid of, that audio only reimbursement will either go away or go down to, and they were paying for audio only prior with all kinds of rules and regulations around it. I would encourage and support doctors and providers and clinics to try to wrap your practice around the ability to utilize telehealth to its utmost highest level of the audio and video. That's going to be your gold standard, because audio only may go away. In the meantime, though, it is really important for you guys to continue to speak up and say how important audio only is, especially for patients that are poor, in the socioeconomic areas that cannot afford reliable broadband. That audio only is truly a lifeline for them to get care. What do you think?
Well, definitely for payment for audio-only telehealth will continue with the adoption of this amendment, HR 2471, under the Consolidated Appropriations Act. Currently, Medicare covers audio-only telehealth under the temporary waiver, but that's going to expire when the PHE ends. And with the amendment, in the new legislation, Medicare coverage of audio-only telehealth services will remain for 151 days after the PHE ends. And without this extension, once the PHE concludes, the emergency waiver authority will end, and so will audio-only telehealth payment and visit coverage. The pandemic and also the adoption of telehealth has, again, highlighted the need and the problem disparity among some people with lack of high-speed broadband internet access. Although someone may have a smartphone, he or she may not have the data plan necessary or having the 4G or 5G coverage so that he or she can use synchronous audio and video telemedicine. So in that case, audio-only visits will pretty much be the only lifeline if they want to continue using telemedicine services. Having the extension of coverage by CMS is going to be really, really good, not just for the patients, but also for the qualified health professional.
Right. Yeah. So I'm going to end it here and just cover those three things. What I'd like to do is also, let's do this again. I'd like to cover licensing and the Interstate Licensing Compact, because that is another hot topic for physicians to, that's another barrier that stands in the way of practicing, and especially with telehealth. So could we schedule, I'll text you, I'll Facebook message you, and we'll do this again?
Sure, we'll reconnect and we'll talk about the licensing and also the medical legal aspects of telemedicine. That'll be fun.
Okay. All right, John, thank you very much. I really appreciate it. And everybody, please follow Beyond Telehealth on Facebook. And also, everyone knows of Dr. Lynn's Thriving Urology
Practice Facebook group. The
practice.
Thriving Urology Practice Facebook group. Yep.
Yes,
Growing like leaps and bounds. And I think we're at 1,800 people. So it's a wonderful group of just US-based urology practice folks. And we are there to help each other thrive and survive.
perfect. All right, stay tuned. Take care, John.
Bye-bye.
Bye.